Alright, so welcome back. Um, Last time we just got up to reproductive physiology, and we're finally about to start looking at a lot more about, how all the reproductive things basically take place. There was one thing I wanted to touch up on from the last video, though. In the end, we had this one question regarding the anatomy of the ureters with respect to some of the arteries. So I found a couple better pictures, and I kind of wanted to just go over that question one more time before we move on to reproductive physiology. And remember, every time you start anything, you should always go back and revise whatever you studied in your last session, right? So this question said a 14-year-old boy arrives in the emergency department after the sudden onset of excruciating left scrotal pain. And you know there's always issues on the left side because the left, what do you call it? The left gonadal vein goes into the left renal vein, right? So that's one thing, and this could be related to that. On physical exam, elevation of the left scrotum failed to alleviate the pain, and stroking the inner thigh failed to elicit the scrotal elevation. Doppler ultrasonography shows decreased blood flow through a specific artery in the spermatic cord. So now this is about an artery, okay? Which of the following structures is located inferiorly to this artery before this artery enters the spermatic cord? And so we're going to be thinking of male anatomy here. And it's always relevant to, this image right here, which is from renal. There's always going to be a question about this kind of thing on your step one, for sure. It's going to be there. It's also a pretty common topic on NBME. So here the answer was just the ureter. They wanted to know what's going to be under the artery, right? So you have to remember water, which is basically your ureter, because urine is mostly water. Water flows over the iliacs and under the bridge, right? So the ureter is under the bridge, and the bridge is basically the artery, right? Because it basically is a bridge that's carrying nutrients and blood and oxygen and all kinds of other stuff like that. So water flows over the iliacs and under the bridge, and that's basically what you're seeing in both of these images. The left one is the male, the right side is the female. So if I make it bigger, just for explanation purposes, we could see here, right? You have your aorta in red, right? You have your testicular artery, and then in the yellow is the kidney and the ureter and the bladder. That's your entire urinary system. And you can see the testicular artery is going over the ureter, right? And then it just goes down and goes to the testes. That's really all. This area in the middle here is pretty much empty in a male, right? In the male anatomy. Whereas in that same middle area in the female, you basically have the uterus. And again, in the female though, thankfully, the anatomy is pretty much still the same in terms of the artery and the ureter. So again, you see you have your ovarian artery going over the ureter. So in both cases, the artery, right, the artery which they're basically pointing out, right, they pointed out a specific artery in the spermatic cord, which is basically your gonadal artery going to the gonad. That artery is always going to be on top of the ureter, and they wanted to know what's under the artery. The ureter is going to be under it, right? So for the female, the bridge is the uterine artery or the ovarian artery. It could be either one, to be honest, because here you can see in the female, right, both of them pretty much go over, right? Even the green one here is showing you more of the uterine artery, and that's the one that you kind of ligate if you want to stop bleeding after delivery or something. Whereas the ovarian artery, that one you don't really want to ligate because that one is bringing blood to the ovaries as well, and if you do that, you'll basically end up killing the ovary. As that's often another typical question you can get. For the male, the bridge is the vas deferens, which bridges life through the delivery of sperm, and that's another thing you're seeing here. Right? That's another thing that's on top of the ureter. As you can see in this image, they don't really talk about the gonadal arteries per se, right? But it's important to know that basically all the arteries except the iliacs. The iliac is the only one that's under it. The iliac artery, as you can see, that's the part of the aorta. The iliac is behind the ureter, okay? But on top of the ureter, you have the uterine artery in females because they have a uterus here. That's the green. And you have a vas deferens in the male. Okay, but those things, again, were not what this question was asking about. They have those answer choices here too, but that's not what this was about. They wanted to know what was under the artery. So don't get too thrown off. There's a lot of things happening here. There are a couple structures here as well, and you need to know the difference between the female and the male anatomy with respect to the ureter, because damage to the ureter is a very common thing, as we saw in some of our previous questions, especially with the females who might get a hysterectomy or oophorectomy. you can always scar the ureter, and then that obviously presents with post-surgical urinary retention, right? So that's going to be something you want to watch out for. And then one thing you always want to make sure you also have revised very well, besides the general anatomy of things, is when we were in the embryology section, make sure you truly understand this page, right? Because they pointed out the issues that can occur in a man, right? If you have an XY setup. Oh, hey, Abhimanyu. Yeah, I'm glad you you find it helpful, man. Here they point out that in a male, right, there can be two different issues that can occur. You can either lack Sertoli cells, which means that you're not going to be able to stop your body from making internal female organs, right, the fallopian tubes, the uterus, and the proximal vagina. Or you can lack 5-alpha reductase, which generally is pretty benign because later on you'll have higher testosterone levels and you'll be able to develop the penis, scrotum, and prostate even better. But other things can go wrong here too, right? You could have a female with Mullerian agenesis, right? In fact, that was something they mentioned up here, right? Mullerian agenesis, Mayer-Rokitansky-Kusterhauser syndrome, MRKH. MRKH is a case scenario where a female may present with primary amenorrhea, right? Because she didn't make the uterus, right? That's the female internal reproductive organ. If she didn't make a uterus, she's going to have amenorrhea. And everything else, though, will be okay in her because she's going to have ovaries, she's going to have estradiol, she's going to be able to have all the secondary sexual characteristics as well as the external female genitalia. The only issue she's going to have is primary amenorrhea, and that's another case scenario you want to remember with respect to this table. Now, with all that being knocked out of the way, we can move on to reproductive physiology. Again, remember, I have notes from everything here, so I have notes from UWorld and AMBOSS as usual, practice questions and notes and images. But for reproductive specifically, I also tapped into Kaplan because a lot of this does need a little more explanation, especially if you've been out of med school for a while and you haven't revised it for some time. You can definitely get some, wicked, twisted questions regarding the genetics of these cells dividing and whatnot. So very important to make sure that you're ready with that. Okay, so let's go into it. First thing we see here are the spermatogenesis topics, right? So everything regarding the development of healthy, successfully well-built sperm. This is a really important sentence. It begins at puberty with spermatogonia. So note that, right? In men, spermatogenesis begins at puberty. And this is not the same. There's a lot of differences. This is not the same for women, right? Oogenesis does not necessarily begin at puberty for females. So make sure you do look at the differences, and I'm going to point it out too. So spermatogenesis begins at puberty with spermatogonia. Full development takes 2 months, occurs in seminiferous tubules, produces spermatids that undergo spermiogenesis, which is basically the loss of cytoplasmic contents, gain of an acrosomal cap, right? So you can see how it started from a circular cell, became something like this, and then you lose all of your cytoplasmic contents, retaining just the nucleus basically, right, which has DNA in it, and then you gain an acrosomal cap, which basically helps penetrate the ovary, not the ovary, the ovum, the egg, to form mature spermatozoa, right? So you went from the left all the way to right. So you have to remember their names, right? Gonium is going to be sperm, and zoon is zooming to the egg. It's already become a sperm. And you can see their names are all here, and they're denoted with this 2N and 2C kind of thing, right? The N and C. So you have to remember N is ploidy, and C is the number of chromatids, okay? Very significant stuff. You can get silly questions where they kind of use that notation, and you don't want to mess that up. So before anything, right, you have this thing, the spermatogonium, right? The spermatogonium is the one that was going to become a sperm, right? Spermatogonium it is diploid, okay? It's diploid. It's 2N and 2C. It's got double ploidy and 2 sets of chromatids. So that's a 46 single chromosomes here, right? 46 single chromosomes. XY. This goes through the tight junction of the blood-testis barrier. And this phase they've written as replication, interphase, right? Mitosis. Okay, so at this point, you're just doing mitosis. You're making more spermatogonia. which are then going to later on undergo meiosis to basically become mature sperm. Very important difference here. This kind of genetics related topic often gets tested, so you don't want to mess that up. In the beginning, all the spermatogonium are generally just undergoing mitosis, and then you get this, right? So now at this point, you have a primary spermatocyte, which is also diploid. However, at this point, something happened, right? It's 2N, the ploidy is still the same, but the number of chromatids it had doubled. And you need to remember that's very important, right? Because if one cell is going to give you 4 sperms, right? If one of these spermatogonium is going to give you 4 mature sperm, then you definitely need to double the number of chromatids you can have, so you can have 4 chromatids, 1 for each guy, right? Totally makes sense, nothing crazy there. So the primary spermatocyte gets ready with that, right? Then that primary spermatocyte is the one that undergoes meiosis 1, right? Meiosis 1 occurs, and remember the differences between meiosis and mitosis, which is very elementary, very, pre-med kind of a topic. So if you've forgotten the differences between mitosis and meiosis, you want to go back and revisit that. But basically, while undergoing meiosis, it's not replication. You're not replicating. You're literally dividing into something that's half of what you had before, right? So you can see how the 46 sister chromatids have been divided into 2 sets of 23 sister chromatids, right? So each one of these is now 1N, right, single ploidy, and 2C, literally half of what a primary spermatocyte was. Okay, so it's not so hard to remember at all, right? The spermatogonium doubled the number of chromatids it had, so it could have 1 chromatid for each sperm in the end. And then from the primary spermatocyte to secondary spermatocyte, this is where you did meiosis, so you halved everything because you're now starting to divide it out. You're splitting it out. The secondary spermatocyte undergoes meiosis 2. And in meiosis 2, you once again divide everything out in such a way that the chromatids are further split up, right? So now each sperm has 1 chromatid. The ploidy cannot go under 1, right? Because ploidy is basically, do you have the entire set? How many sets do you have? And the primary spermatocyte had 2 sets of everything. That's how it was able to have 4 chromatids, 2 sets. Those 2 sets with 4 chromatids got split up, and you get 4 things after that, right? So that's the final product right here, the spermatid haploid, right? And this spermatid, which is haploid, has to now become fully equipped so that it can travel and go impregnate someone, right? So now from here to here is just a bunch of physical changes, as they said here: spermatogenesis, loss of cytoplasmic contents, gain of an acrosomal cap, addition of a bunch of things to the tail. It becomes much more adept than it is over here. And the tail is also very significant, right? Because remember right here, right, impaired tail mobility can lead to infertility, which is seen in ciliary dyskinesia, Carter-Jenner syndrome, not in cystic fibrosis, right? So you don't want to make that mistake. Be ready with that. Cystic fibrosis is a whole different issue where someone cannot get pregnant, but it's not because the tail is not working. And back in biochemistry, when we were looking at the differences between the two, we spoke about a couple key differences. So I'm going to go back and revise that with you guys for completeness. Let's see. I think that was genetics. Yeah. Right, so let me see, cystic fibrosis, and then what did they talk about? Carter-Jenner was a whole different chapter. Okay, so right here, cystic fibrosis, right, you can have infertility, right, infertility in men, not because spermatogenesis had an issue, but because you don't have a vas deferens. No vas deferens, right, so spermatogenesis may be unaffected. And then in women, you can have subfertility, a lot of difficulty getting pregnant, and remember, getting pregnant is already hard. So subfertility is also pretty significant in women, where they can have amenorrhea or abnormally thick cervical mucus, which obviously messes up the travel of the sperm. Okay, but here, don't pick cystic fibrosis for an issue with the tail. The tail is fine. In cystic fibrosis, you don't have the vas deferens. Okay, in males. So now here's a couple things from Kaplan, and then a question that really summarizes something that we're going to be this question summarizes a lot of things that we're going to be looking at when we actually start looking at real questions in step 1. So for spermatogenesis, a couple Kaplan notes on the top. The events inside the nucleus are the same for males and females, but the division of the cytoplasm is different in both genders. Spermatogonia or oogonia are somatic cells, not gametes. So they divide by mitosis until they enter meiosis, and this point is different in both genders. Now they become spermatocytes or oocytes and enter the first meiotic division. The first thing that occurs is the replication of DNA, thus doubling the amount of DNA we had. So 2n becomes 4n. Initially, we had one pair of chromosomes as a 2n cell, and now we have a 4n cell because each chromosome has 2 strands of chromatids. It is still 46 chromosomes, it's just that now they are double-stranded. At the secondary spermatocyte point, we have 2 cells each having 1 chromosome from each pair. So now we have 23 chromosomes that are double-stranded, so the 23 1n2c notation, which is just a revision of what we just looked at. There are half as many chromosomes, but twice as many DNA in each secondary spermatocytes or oocyte. In males, meiosis 1 does not start until puberty. So before puberty, there is no meiotic activity in male gonads. This meiosis then happens from puberty until the day of death continuously in males, right? And that's a very critical difference between males and females. And then when we get to the female part, which is going to come after estrogen, progesterone, we'll look at oogenesis, we'll see the difference there. But before we get to that, I want to look at a typical question you can get regarding reproductive development. So this one, 32-year-old woman, G2P1, with an uncomplicated prenatal course, delivered a 4.1 kilogram or 9-pound newborn at 39 weeks gestation via spontaneous vaginal delivery. So all of that looks okay. APGAR scores were 8 and 10 at 1 and 5 minutes, which is perfectly fine. Further evaluation of the newborn nursery shows abnormal sexual differentiation. That's the problem here. So now you know your topic in this question is going to be about that. Karyotype analysis shows a 46XY chromosome genotype, right? So now you know also that it is a male and it's not, XXY or anything weird like that. Biopsy of gonadal tissue shows a lack of Sertoli cells, but normal Leydig cells. And at that point, you should immediately know what went wrong. Which phenotype or what phenotype is most likely to be present? And then you get these answer choices, okay? But D was clearly and most evidently the correct answer here, because if you lack Sertoli cells, remember what Sertoli cells did? They secreted Mullerian inhibiting factor or anti-Mullerian hormone. And the job of that Mullerian inhibiting factor was to get rid of the Mullerian paramesonephric final products, which basically were your female internal organs, right? Female reproductive internal organs. The Mullerian thing basically gave you the uterus and all of that. Now, here, without the Sertoli cells, you're not going to be able to get rid of that. And they said they have this male fetus or this male infant has normal Leydig cells, which means that the release of testosterone is going to be fine, and he should have a perfectly okay external male genitalia. So at that point, you can start knocking out answer choices, right? You can knock out A, C, and E because he should have just fine male externals. So you're really just down to B, D, or F. That's half your answer choices gone. Now, what is his internal reproductive organ going to be? Well, he should have the male internal reproductive organs. There's no reason that's going to disappear. But he's also going to have the female internal reproductive organs because he didn't stop it. The Sertoli cells didn't inhibit the development of the Mullerian ducts. And that's how you come down to answer choice D, is the only one that has the correct combination of things. So what are these other answer choices? These other answer choices are actually not from the reproductive chapter. They're from the endocrine chapter. Those other things are more so likely with congenital adrenal hyperplasias. Choices A and B are related to a normal XX embryo, right? Because you can see in both of them, they have female internal reproductive organs. The only way you can do that is if you didn't have an XY chromosome or you didn't have the SARI gene, right? That's another pathology that can occur. The presence of external male-type genitalia or ambiguous genitalia, as you can see in both cases, is consistent with androgen excess, right? Which is seen in 21 hydroxylase deficiency or 11 hydroxylase deficiency. Remember the way we memorized all of those congenital adrenal hyperplasias? If the 1 is high, if the second digit is high, just for a quick revision of that, I just want to show you guys something. Remember that in your congenital adrenal hyperplasias, it was all about GFR, right? And the F, fasciculata stuff, all the cortisol was always low. So that was never a concern. Now, you really just have to worry about this one or this one, right? And each number, like 21, 17, and 11, right? Each one of them has a 1 in it, and when you look at a 1, you want to think of it as like an arrow pointing up, right? So that's basically what you want to think of. So in 21, the second thing is high, right, which is your androgens. In 17, the first thing is too high, which is your G, right, the glomerulosa stuff, which is basically a lot of aldosterone. And in 11, both of these things are high. But right now, when we come into reproductive chapter, what we're truly worried about is whether or not the androgen stuff is high, right? If the androgen stuff is high, that's a problem. That's going to be excess androgen activity, and excess androgen will often cause realization, right? And that's what you see in both 21 and 11. Excess androgen, so you end up having male type or ambiguous genitalia in a female. In a female, the internal reproductive organ is the real key giveaway of whether or not a patient is XX or XY. The external genitalia is more so physical development, which is due to hormones or lack of something or excess of something. Okay, choice E, right here, choice E, 24% of people picked it, where you have male internal and then female and male external. This one is actually the 17-hydroxylase deficiency, right, leading to undervirilized external genitalia in a male. Because remember, in 17, we just said that the only thing that was high was the first thing, which is a lot of aldosterone, but then the other two are low. So you're not making enough testosterone in that case. So you got a male who has female type or ambiguous genitalia, right, not making enough testosterone. So this question does a really nice job basically tying congenital adrenal hyperplasias with reproductive development, because those two things are often tied together, and you have to make sure you know how to differentiate between them. All right, because the only other thing we saw was non-functioning Sertoli cells, Leydig cells that don't release enough testosterone, or lack of 5-alpha reductase, and then Mullerian agenesis. Those are the only few other things we've seen so far. All right, so moving on now, we're going to look at the two critical female hormones. There's estrogen and progesterone, right? Very high yield, obviously. You definitely need to know them no matter what field of medicine you work in. So estrogen, source is the ovary or the placenta or even adipose tissue, right? Via estrone aromatization. If you didn't know that one, you might have recently started studying or completely skipped your mind, but you got to remember that. And that's very significant, because if you're working with an obese patient, you have to keep in mind adipose tissue can also release estrone. So what is the difference between all of these, right? Estradiol, estriol, and estrone. So this is basically listed out right here based off of potency, how effective they are in doing what they're supposed to do, right? How strong they are. So estradiol is the most potent, which is the one coming from the ovaries. Estrone is the least potent. That's the one that was coming from adipose. And estrone is middle, and estriol is the least potent of all of them, which is the one coming from the placenta, right? So I came up with a little thing when I was studying for this. Being two is better than being alone, right? So estradiol is better than estrone, and pregnancy has 3, and a pregnant woman is very susceptible, right? Very susceptible to attacks and very sensitive to teratogens, all kinds of things, right? You often just think of a pregnant woman, for test purposes, as someone who is very susceptible, right? She can't really fight for herself, she can't run, etc. So that's the little thing I made up to remember the potency stuff, right? So diol, estrone, and estriol. Estriol is the weakest one, the one that comes from the placenta. Right? So it's pretty significant to know that estrone is even more effective than estriol, more potent than estriol, right? So keep that in mind, because you can get a stupid question where they want you to put this in this order. Now, what is the function of estrogen? So development of genitalia and breast, female fat distribution, growth of follicle, endometrial proliferation, more myometrial excitability, upregulation of estrogen, LH, and progesterone receptors, leading to feedback inhibition of FSH and LH, then an LH surge, stimulation of prolactin secretion. What is all of this? So this is basically the intricate interplay that you're going to be looking at when we look at menstruation, okay? You remember from menstruation, LH surge was obviously a pretty big deal, right? And then later on, the stimulation of prolactin secretion is also another really big deal that women have to be concerned with after delivering a baby. So these are things that are going to occur. You don't necessarily need to memorize it like this, the way they wrote it here. I personally don't really like this little blurb here. I'm not sure what the purpose of it is, but it kind of tells you that some wicked shit is about to happen right now. The last thing is this thing. More transport proteins, right? Estrogen increases the amount of transport proteins you have. So sex hormone binding globulin increases. You also end up having more HDL and lesser LDL, which is great. That's a good thing. Okay. On the right side, they talk about pregnancy. So pregnancy has a 50-fold increase in estradiol and estrone, but a 1,000-fold increase in estriol, which is, remember, the one that's coming from the placenta. So estriol is an indicator of fetal well-being, and a test question can ask you, which of the 3 hormones would you check for to see how well the fetus is developing? You would check for estriol. Estrogen receptors expressed in the cytoplasm translocate to the nucleus when bound by estrogen. This topic is actually a pretty common thing in any question that's trying to test you on receptors per se. And we've talked about this already. So let's take a look at where we talked about this, because it's very important to also always go back and review this whenever you see it. So I think it was, where was it? Endocrine. Where's the receptor stuff? Yeah, right here. Okay, so at the end of endocrine physiology, right? The last page has signaling pathways of endocrine hormones, and you obviously definitely need to know all of these, and the ones you want to spend the most time on are the last 2 here, because these should become very easy over time. IP3 is the hardest one to memorize because there's no real setup here. Like, everything here is just a mix. They're not all the same type of hormones. And then on this side, right, the latter half of the page, they talk about signaling pathways of steroid hormones. And you have to remember that the receptor of steroid hormones, like estrogen, testosterone, all of that stuff, is in the cytoplasm. And then it translocates into the nucleus once it binds whatever hormone we're talking about. All right? So this is what we just saw when we were looking at estrogen right now. So this kind of thing I've seen many questions on, definitely on NBME, definitely on a bunch of people telling me, what happened on their step 1, what topics were pretty common on it. And it's something that, test writers love throwing at you because people don't spend enough time on it, right? It's a very annoying page to spend time on. But this page, as you can see from all my notes, and every time we've talked about it, you have to come up with things to really help yourself memorize this, right? The better you come up with stuff, the easier this becomes. And right now we're looking at these guys, right? These are the guys we're truly focusing on right now. These are intracellular receptors, all cholesterol derivatives, right? And you know this because when we were doing endocrine earlier, looking at the same page of congenital adrenal hyperplasia, cholesterol is what we use to make progesterone, estrogen, and testosterone. Okay, so as cholesterol derivatives, they're very lipophilic in a sense, right? And these guys have to use intracellular receptors. Okay, these guys all, I wrote here, these hormones activate intracellular receptors to induce them to bind to the promoter region of target genes to modify transcription. They act directly as transcription factors and contain zinc finger domains. Okay, so very significant stuff. I know it's not important stuff for you to become a doctor per se, but it's definitely important stuff for you to pass step 1. So that's what they wrote over here again too, and it's definitely worth revising. So what else is here now? You can see there's a couple cell types that they don't really write much about here. You have theca cells and granulosa cells. Okay, the theca cells are the outer layer, right? So what we're looking at here is basically what we've been seeing ever since we started embryology, right? So you have your implantation, basically, that's the egg and all that, right? So theca cells are the outer layer, right? This is the theca cell here. What is the theca cell doing? So the theca cell has a LH receptor. LH comes in and increases the amount of cyclic AMP you have here. That cyclic AMP upregulates the activity of desmolase, right? And we've seen desmolase already. We saw desmolase and aromatase earlier when we were looking at congenital adrenal hyperplasias, right? So there's a very strong tie between endocrine and reproductive, because in endocrine we didn't talk about these hormones, right? We didn't talk about sex hormones. We only talked about all the other hormones like ADH and aldosterone and cortisol and stuff like that. So here, desmolase basically breaks cholesterol down and makes androstenedione. Okay, now that androstenedione goes through the theca cell and goes into the granulosa cell. Granulosa cells have an FSH receptor, which also increases cyclic AMP, as we just saw on the previous page we were doing with the endocrine receptors. Right? And cyclic AMP here upregulates the activity of aromatase. Aromatase's job is to take androstenedione and make it into estrone. Right, estrone. And that is the middle guy right here. Right? Estrone and estradiol are going to cycle in between depending on whatever is necessary. And you ultimately end up releasing some form of estrogen. Okay, so fetal placental aromatase deficiency is a significant thing that can occur. I've put this image here, but we're going to talk about this again later on too. But what basically happens if you don't have aromatase, then all this androstenedione is going to stay androstenedione, right? And that's what they're showing you right here in the middle. So on the left, you have the mother who's sending LDL, right, and sending dihydroepiandrostenedione into the placenta. Right? On the right side, you have the fetus. The placenta's job was to take this DHEA and take all the cholesterol and eventually make androstenedione, which would then become some form of estrogen. If you do not have aromatase, right, aromatase deficiency is now another topic you can add to your list of things that can occur in reproductive fault. Without aromatase, all that androstenedione goes to 17-beta hydroxylase, and that becomes testosterone. Right, so now, instead of making estrogen, you ended up making too much testosterone, which actually ends up affecting both things. The testosterone goes back and affects the mother, causing maternal virilization, so the mother might start having like facial hair, right, anger issues, stuff like that. And it also causes virilization of the female fetus. Right, virilization of the female fetus. And this doesn't occur that often. It's very rare to see this. The only times we saw virilization of the female fetus were these acid traces here. Right? If you have a female fetus with male type genitalia, it's because you have too much testosterone, such as in 21 and 11 hydroxylase deficiency. Now here, this is another one, which is aromatase deficiency. Okay, so very important to keep that in mind. This tie we're going to see again later on too. And one more thing I wrote over here is just the analogy type of questions you get. So theca cells are very analogous to the male Leydig cells, right? Male Leydig cells and female theca cells, they serve a very similar type of function, right? And then the granulosa cells are analogous to Sertoli cells, okay? So this little analogy thing often shows up, very much worth noting, because you get a stupid question where they say, you know, what female cell is analogous to a Leydig cell. So you have to make sure you get that correct here, okay? So that's a silly little thing. How you memorize it is completely up to you. For me, it was that I was able to remember theca cells use LH, and LH starts with an L, right? L for Leydig cells. That's it. FSH goes to granulosa cells, right? And look, granulosa has an S in it too. FSH has an S in it, and all of that is related to Sertoli cells. And so it's a silly little thing, but it works for memorizing this, so you don't have to like sit down and really hardcore study it. The latter half of this page talks about progesterone, and then I have questions from UWorld and AMBA. So let's read progesterone and see what's happening. Progesterone is progestation, right? Progestation is it's really necessary to help with pregnancy. Corpus luteum, placenta, adrenal cortex, and testes all can release progesterone. What is its function? During the luteal phase, it prepares the uterus for implantation of a fertilized egg, right? So we're talking about the luteal phase of menstruation, basically. So a stimulation of the endometrial glandular secretions and spiral artery development, and we're going to see all of this soon enough. Production of thick cervical mucus, which inhibits sperm entry into the uterus. Prevention of endometrial hyperplasia, right? So that's a good thing. If you don't have enough progesterone, or if you're taking progesterone antagonists of any kind, you can end up increasing the risk of endometrial hyperplasia. It also increases the body temperature. A silly little thing you can definitely get a question on, and I'll show you why when we look at menstruation. It decreases estrogen receptor expression, which totally makes sense because you don't need both of them working too hard at the same time. And it also causes a feedback and decreases gonadotropin secretion. Now, if implantation and fertilization, all that stuff occurs, then during pregnancy, progesterone is there for maintenance of pregnancy. Okay? Decreases the myometrial excitability and decreases contraction, thereby allowing the endometrium to sit. And it also decreases prolactin action on the breast. And we saw this in endocrine. Right? Progesterone and prolactin don't work at the same time. So if you're pregnant and you're releasing a lot of progesterone, you will not have much prolactin activity on the breast. As soon as delivery occurs and progesterone secretion decreases by a lot, now prolactin activity increases on the breast and you can have lactation. A fall in progesterone after delivery, and that's basically what they're saying right here, right? Fall in progesterone after delivery disinhibits prolactin, which allows lactation. Right? High progesterone is indicative of ovulation. Right? So this sentence is very important too because everyone's used to the concept of LH surge, right, for ovulation. But LH surge is not the real giveaway of ovulation. It's an increase in progesterone. And there's a question here that we're going to see that in. So let's take a look at these questions. First one here, Amboss, 47-year-old woman, comes to the physician because of fatigue, difficulty falling asleep, and night sweats for the past 6 months. Over the past year, her menstrual cycle has become irregular, and her last menstrual period was 2 months ago. She quit smoking 2 years ago. Pelvic exam shows vulvovaginal atrophy. A pregnancy test is negative. What change is most likely to occur in this patient's condition? So what's wrong with her, right? What is all of these things that she's exhibiting, right? Fatigue, difficulty falling asleep, and night sweats, okay? And then her menstrual cycle has become irregular now. Last period was 2 months ago, right? The smoking thing is just extra stuff that's there that's obviously relevant, but it's kind of not so relevant at the same time. But then the physical exam is always the high yield stuff you want to look at, right? And they tell you it's vulvovaginal atrophy. Why would you have vulvovaginal atrophy? So the answer here was increased FSH, which is definitely a harder answer choice to pick than what's truly happening. But basically her thing is increased levels of FSH are most likely to be seen in this patient. Menopause, which is what's basically happening to her, is usually preceded by the climacteric period, in which the menstrual cycles become increasingly irregular before amenorrhea begins. Ovarian failure leads to a decrease in the circulating levels of estrogen and progesterone, and those were the easier answer choices to pick. Low estrogen and progesterone, resulting in a decrease in negative feedback to the hypothalamus. That negative feedback no longer is there, resulting in an increase in gonadotropin releasing hormone levels and subsequent increase in FSH. Right? So you see how progesterone decreases gonadotropin secretion. Without the progesterone, without the estrogen, you're going to have too much of that. Okay? So when we look at menstruation, we're going to see that when you get to menopause, one of the big signs of menopause is increased FSH. One of the big signs of ovulation is increased progesterone. Right? So definitely don't mess that up. And I think one of these questions is about that. No, neither of these is. We're going to see that though. After oogenesis, the topic is the menstrual cycle. Right? And you can see how high progesterone is a big deal here. Right after ovulation. Of course, the LH surge is necessary for ovulation, but there's a bunch of stuff that's going to happen, and we're going to see those questions when we get there. Excuse me. So, anyway, right now, 2 more questions down here. Ureter and Amboss. So, 35-year-old Caucasian primigravida is found to have gallstones at 38 weeks gestation, 38 weeks of an uncomplicated pregnancy. Ultrasonography performed 1 year ago failed to demonstrate any abnormalities. Okay, what pathogenetic components most likely contributed to her condition? All right, so why does she have gallstones? Why does this pregnant woman suddenly have gallstones? This was an excellent URL question to really tie this connection, so make sure you catch this. Estrogen-induced cholesterol hypersecretion and progesterone-induced gallbladder hypomotility was the answer. Okay, and those are things that both of these hormones do. Right? Did they mention it in here? They didn't really put it here, right? That's why I put this question here. Because they do mention this in other places. I think earlier in endocrine they talk about it a little bit. And throughout reproductive, we're going to see more of this too. But pregnancy and the use of oral contraceptives predispose women to gallstone formation. Estrogenic influence increases cholesterol synthesis by upregulating HMG-CoA reductase activity, which causes the bile to become supersaturated with cholesterol. Progesterone reduces bile acid secretion and slows down gallbladder emptying. Those two things combined leads to the formation of more gallstones. Okay, it's a very important thing to keep in mind. Estrogen and progesterone are not just related to one thing. These are hormones that cause very systemic, right? From head to toe, everything gets affected. And of course, for females, emotional liability, mental effect, right? Everything, physical effect. And pregnancy and oral contraceptives are a huge interplay of these hormones. So you have to be aware of these things. Now, of course, if you put someone on oral contraceptives, or someone gets pregnant, and this patient is someone who's in some way predisposed to possibly getting gallstones, you definitely want to put them on statins, right? Put them on statins so you can reduce the risk of gallbladder gallstones, okay? Last question down here from Ambos. This one says, a previously healthy 37-year-old woman, G3P2 at 29 weeks gestation, comes to the physician because of colicky postprandial abdominal pain. Her vital signs are within normal limits. Physical exam shows the uterus consistent in size with a 29-week gestation. Ultrasonography of the abdomen shows multiple hyperechoic masses within the gallbladder lumen. Which of the following processes is most likely involved in the pathogenesis of this patient's condition? Same exact case again, right? But now Ambos's version of the same exact question, right? Very well written question, perfectly designed. Everything is very accurate. And the issue here is the same issue as in the last question above it. It's increased secretion of cholesterol, which is due to estrogen. Beginning in the third trimester of pregnancy, increasing circulating estrogen levels result in an increased hepatic cholesterol synthesis and the formation of cholesterol supersaturated bile. And keep in mind, one of the reasons you're making all this cholesterol is because you're going to use it to make a shit ton of estriol, right? Because this woman is pregnant. Moreover, higher progesterone levels cause smooth relaxation, right? Smooth muscle relaxation, decreased and incomplete emptying of the gallbladder, and subsequent bile stasis. Together, cholesterol-rich lithogenic bile and gallbladder stasis predispose to gallstone formation. Similarly, hormone replacement therapy and oral contraceptive use also predispose to cholelithiasis. Right? Lit is basically a stone, right? So keep that in mind. Lithogenic means stone-genic, right? So something that can make stones. So clearly a pretty important topic to know. A very twisted topic because it's like you're taking sex hormones and you're combining it with gallstones, right? GIT and reproductive, as well as a little bit of endocrine combined in this question. So it's a very nice question to test somebody on. You want to make sure you get this stuff down very well, okay? And that's basically it for all of that. In the next video, we'll go into oogenesis and ovulation and take a look at the almighty menstrual cycle.